All right. Hello, everyone. Thank you so much for joining us today. My name is Cynthia Klein, and I serve as the Project Director for the Agency for Healthcare Research and Quality's Take Heart initiative. On behalf of our full team, we'd really like to welcome you to today's session. We will be entering back into the topic of automatic referral today. This is the second of two modules that we have on this topic, and today's session is titled Troubleshooting Your Automatic Referral System. On the next slide, so today's presentation is the seventh in a series of 10 modules, so we're well past the halfway point, and it's designed to provide implementation support and share best practices with Take Heart hospitals implementing automatic referral with care coordination. As you'll see on the bottom left-hand corner of the slide, as a reminder, all of our Take Heart training modules are guided by the roadmap that's been established by the Million Hearts Cardiac Rehab Change Package, which is located within the Resource Center on the Take Heart website. Also, as a reminder, the format for our sessions is, or format for our training modules is a session like we've got today, in which we include subject matter experts for the presentation, and then also have the opportunity to do some online discussion with other participants and to be able to share challenges, concerns, but also do a little bit of that peer-to-peer sharing. You'll also receive after this session written guidance materials in the form of an implementation guide that is intended to help reinforce and supplement the material that's presented today. And then we also have technical assistance that follows with the partner hospital peer action groups, again, where you can share ideas and be able to strategize a little bit in terms of successes and where you've had challenges implementing each one of these steps. Per usual, we are offering CEU credits for today's participants. So you'll see an email about this that follows this session that'll have some additional details on how to claim those. And then one last slide for me. Really in today's session, we're hoping to have everyone participate. We'd like to hear from you. So at the bottom of your screen, you'll see a conversation bubble that's similar to one that's pictured here. If you click on the bubble, you'll open the chat box. The only thing we want to remind folks about is if you can go ahead and set the to field to everyone so that we can all see your question and all see some of the responses that go back and forth. I think with that, I'm going to go ahead and pass it over to Steve Hines, who's going to take us on our next step in this journey. Thanks.
All right, good afternoon also to everyone, and we're delighted that you're here and looking to just contextualize. We know we have these sessions once a month, and it's easy to kind of lose track of how everything fits together. But just as a reminder, in Module 4, we talked about the importance of data to supporting both care coordination and automatic referral. And then in Module 5, we talked about how to get the process started for automatic referral. And then to give you a little time to get going on that, we spent Module 6 last month talking about care coordination and laying the groundwork for that. So this month, we're back to Module 7 and automatic referral again, and talking about how you can troubleshoot and fully implement your automatic referral system. So goals for today, you can see them on the screen. We want you to understand how to test your automatic referral order set and how to communicate and educate and support the process as it goes live, how to develop your data and feedback monitoring plan, and then the very important issue of troubleshooting. You're not going to do automatic referral perfectly when you flip the switch for the first time. That's natural, and we expect that. So figuring out how to fix the challenges that surface, how to get people's buy-in is really critical, and that's the focus for today's session. So just as a reminder about Take Heart, it's a process that involves both automatic referral and care coordination, because the evidence is very clear that when you combine an automatic referral system and enhanced care coordination, that leads to increased cardiac rehab participation and ultimately to better outcomes for all of those patients that participate. And the thing that we want to stress is that automatic referral, implementing that is going to place more stresses, and it's going to place more importance on your care coordination system, because the more patients that you correctly identify as needing to be automatically referred, the more you're going to have to support the care coordination of those patients and make sure that they get into the project, as you can see on the next slide. So automatic referral isn't a substitute for care coordination. More referrals should translate into more care coordination and more improved health and well-being for your patients. So when we're thinking about automatic referral, we just want to stress that there are different ways to implement automatic referral, and ranging from the easiest, which is just focusing on automatic referral from your hospital into your own cardiac rehab program. And if you're a small program, or if you want to start the most modestly and quickly, that's the way that you should be doing. At the other end of the spectrum, there are programs that have very sophisticated automatic referrals that involve referring patients to external programs as well, or involving referrals that are coming in automatically from outpatient practices as opposed to the hospital. We don't encourage that you try to do all of that at once. Start simple and then go from there. And you're likely to be more successful in the short run and in the long run. So as a reminder, in automatic referral, as you look at the next slide, in Module 5, we talked about creating the aim and doing your initial planning, and then starting to do your testing. And then today we'll pick that up in Module 7 by talking about the remaining issues that you see on the screen. Now, that's not me that's doing that talking. Instead, the two presenters today that you'll be listening to are Sherry Kadanga, who's a cardiologist and assistant professor of medicine at the University of Vermont, and then Laura Louie, who's the EHR manager of County of St. Barbara Public Health, and an Epic implementation manager, and a real expert. And both of them have gone through the process of implementing automatic referral. Now, in addition, we've got Kathy Briggs on the program live, and she is going to be providing some insights from her perspective as a prior participant whose program has implemented automatic referral. So before we start listening to Sherry and Laura, I'm just going to ask Kathy to say a few words, provide a little bit of background on how they implemented automatic referral in their program, and what about the Take Heart initiative was useful to them in that process.
Thanks, Steve, and thank you to Take Heart for developing this initiative. I have been just honored to be in one of the cohorts, one of the most recent cohorts that completed, and it has been an amazing journey. I can tell you every single session I learned something. I've been at my hospital for 23 years and been in cardiac rehab for, I don't even want to tell you how many years. I'm old, I'll say that. And this Take Heart initiative really has solidified a lot of what I already knew and allowed me to continue the journey to really delivering some high quality cardiac rehab. At our hospital at East Alabama Medical Center, we're just a 350 bed rural hospital. We use Cerner as our EMR, and I was fortunate to be here when they implemented Cerner, so I was allowed to, I'll call it, plant the seed for automated referral back then. We put a consult to cardiac rehab in Cerner that would automatically go to a multi-patient task list, and then I assigned staff who look at that task list every day. So we planted the seed for automatic referral quite a few years ago, and it has continued to evolve over the years, where we have added automated consult to cardiac rehab. We have added into order sets or power plans as opt-out only for our physicians. And so we just continue to evolve our automated referral processes, and Take Heart has allowed us to really drill deep into it and look at some things. And later I'll tell you some of the things that we've changed and improved.
Thanks very much, Kathy. And we really want to encourage you to put questions or comments into the chat. We'll respond to those as we're listening to Sherry and Laura, and then also we'll discuss them with Kathy after we hear from Sherry and Laura. So at this point, I'm going to turn it over, and we're going to hear from Laura first, and then Sherry about their automatic referral experiences.
All right, excellent. Thank you, Stephen. All right, so where I'd like to begin with everybody today is just a quick reminder that I think a lot of what we're going to talk about today refers to the process for a go live. And these are all things that I personally have used in an implementation of Epic, in different upgrades with your EMR system. And so we're going to talk about all of the best practices of that, but as you are implementing AR automatic referrals in your system, you may find that you need some of these, or maybe you are a really big system and you need all of these best practices for go lives, but just keep in mind that maybe you don't need all of these for your system, that you might just need a few depending on your process and your organization. So, all right, from this, what we're going to talk about is really setting up your testing process in preparation for your go live. So bench testing, if anybody is familiar with this, I am a big fan of this from the EMR side, and really what bench testing refers to is your testing of your AR build within a fake environment, basically. Your EMR team is going to know that your bench testing needs to take place in a fake environment. I highly recommend that this be in an environment that is a copy of your production environment that has up-to-date patient information as much as possible. But what you're really going to be testing out within this is your exclusions and your criteria that cause that automatic referral to kind of fire. So all patients, you want to make sure that the criteria that you've set for the patient to actually be referred on an automatic referral is triggering correctly, whether that's diagnosis or a specific order is placed, whatever signals in Epic that that patient needs to be referred. And then any exclusion criteria, meaning this patient should not have that referral sent. This is kind of your opportunity to test both of those and make sure they are firing correctly. The action on this, the more comprehensive and the more thorough that you are, both from the cardiac rehab side and working with your physician champion or your physician supervisor related to this, the more specific you can be for someone in my role that's in your EMR, I think the better the results are going to be for this process for you. So as a programmer, I want to know kind of what your baseline workflows are in building this out for you. So, and those exclusions and criteria. So if you come prepared with those, it makes it a lot easier for it to be specific and to work correctly. And we're going to do that from this fake environment with bench testing. So pilot testing, also very, very important. Pilot testing is what you are going to do and prepare and work with, again, your EMR and your cardiac rehab staff, as well as your physician supervisor or champion, if you can get them. This is going to be in a live environment with a very small select group. From an EMR perspective, we try and keep those fake environments as up to date as possible, but you're always going to want to do your bench testing in a fake environment and then your pilot testing with a very small group who knows this workflow well in your real environment before you set your go live. And depending on how that goes, again, looking at your exclusions and your criteria, that's when you can kind of start to prepare and plan for that go live, which is what we're going to talk about in the next few slides here. But that's really important on your pilot testing side, so please keep that in mind. All right, so for our next couple of slides, we're going to talk about your team that should be involved in your build from start to finish for your automatic referral. Our initial one is just going to be some type of executive, clinical, and if possible, EMR/IT. That's just going to really signal how important your automatic referrals are and that you have leadership involvement in that. Executive clinical leadership is really, really important. Again, That's who's going to help you build out those criteria and those exclusions to work correctly. Your next two staff that are going to be involved in this are going to be your QI and data analytics coordinator. In some organizations, I think this is maybe going to be the same person. I know I have worked in one where QI and data analytics was really kind of wrapped up together, and maybe you have one person, but your QI leader is who's going to help you set up your data monitoring plan. They know the data, they know how to interpret it, they know how to get a story out of that data and what's really happening. Your data analytics coordinator is maybe somebody slightly more technical who knows how to go in and actually extract that data in a way that will make it meaningful, and they'll usually work really closely with your QI lead on that. All right, and your EMR/IT staff, some organizations, mine for example, we are a separate clinical informatics team from IT, but sometimes those are together. But what I'd like to stress about your EMR team is just that for any go live and for your AR build, that you have made sure that your EMR person, your analyst, your go-to has been working with you from the beginning of this process. They should know your baseline workflows. They should know your new workflow. They should know how to roll back changes if it is needed for this. So as much as possible, keeping one person and keeping that person consistent is really important, at least from where I stand on the EMR side. Okay. Your next group on this, your cardiac care providers and your clinicians, of course, they're going to be very heavily involved. This is kind of almost your end user group, however. After you finish your bench and pilot testing, this is the group that's going to need to receive the training. And this is going to give you feedback on how your automatic referral works for them. So this is kind of your end user group, if you will, on receiving that. Your next person here, your cardiac rehab champion, this is really your communication lead. This is your passion person. This is your why are we doing this person. So it's really important to have this involved and have that be somebody who knows cardiac rehab well. We'll talk a little bit more about the communication responsibilities of that cardiac rehab champion in just a little bit, but and then of course your cardiac rehab clinicians and your team that works closely with cardiac rehab, they need to know this workflow inside and out. They need to know how your cardiologists, how your providers are ordering these referrals to be able to help troubleshoot if you find down the line that this is not working as you anticipated. So don't forget your own staff and your own team and make sure they really know the workflow well too. And lastly, just a quick reminder, don't forget about the patients. They are a great source of information and data to say, did this work for you well, or not. So just don't forget to include the patient as you think through these. All right, great. So that communication piece that I said we were going to talk about for your cardiac rehab champion. This again is your passion person. This is your communication liaison. If anybody has a question on why you are trying to implement automatic referrals, this person should have that knowledge at the ready. They should be able to speak passionately about it. It will show through that they know this and they know this well. So in terms of communicating, one of the things to keep in mind is that you probably want to have not just like an elevator speech ready if there are questions, but you also want to have at least a one-page overview, and please try and keep it to one page if you can. People appreciate, especially around go live precision and being concise and getting the message across. Try and use graphics as much as possible. We all like pictures. It helps depict that. So again, keeping that to one page, having that at the ready, and then just remembering as that cardiac rehab champion that as you're prepping for go live, it's really hard to over communicate. People don't tend to be like, wow, they really over communicated with me on that go live. So, have those conversations, get spots at department meetings if you can to explain the why and the when is really the critical parts to this. Okay, go live support. So if anybody has ever been involved in an EHR go live or a large update with an EHR go live, these are again some of the best practices with this, but please take this, take pieces of this and apply it to what your organization needs, and you know your organization's best. So one of the things from an EMR side that we're always going to do is we try and prepare for a worst case scenario. And from where I stand, if we have a worst case scenario process, it just means that I'm going into Epic or whatever your EMR's live environment is, and I'm rolling those changes back. So I am not, we really shouldn't be dropping the paper or anything. We're just rolling changes back out of the system, which is, again, why it's really important that your EMR person be consistent and know those workflows, because good change management will have them, they'll know how to do that very quickly if something goes awry. Again, for an Epic go live or for an EHR go live, we always have a hotline number, we have emails, we have all of that. Depending on your organization, if you have the resources for that, it's always a good idea. As much as you can, help people get this right from the start if they're having issues. But the one I will most strongly recommend, if you can and you have the staff, is to give what we call some elbow support. So that means that somebody is right there to help the providers, to help the clinical staff on the inpatient side that are placing these automatic referrals. If you can get behavior change is always difficult. If you can get them ordering these correctly using your automatic referral workflow right from the first time they do this, and have them practice that correctly, you're going to be really set on this being correct down the line. So think about that. If you can provide elbow support, it's helpful. And then, of course, represent on all shifts if you can, and snacks. Can't overlook snacks.
Laura, can I just jump in with a quick question here? There are some people that may have seen that first line about preparing for the worst case scenario and become very nervous because of that. So what really is the worst case scenario? And that might be a little reassuring for people if you could answer that.
Yeah, absolutely. So a worst case scenario, from my perspective, Stephen, having been in a go live, is that maybe your automatic referral is not triggering. Maybe a provider isn't actually finding an automatic referral, or those referrals are not available. From where I stand, Stephen, a worst case scenario is that it is causing errors in patient data and patient care, or it's just not working as you intended. And that for me would be rolling back anything that we've implemented for that go live and reverting to a previous workflow. So I think everybody, maybe not everybody, but I certainly have been involved with go lives where some go lives go great, some go lives definitely have some struggles. And in terms of avoiding causes of failure, the most important thing that I would prefer to highlight around issues with a go live are actually related to workflow issues. For example, 4 years ago, we went live with Epic, and we had a couple of clinics take a different stance to training. And from the workflow perspective, we had one clinic heavily focus on workflow and one clinic heavily focus on functionality. And really if you focus on workflow issues from the start with training, I think it kind of helps alleviate provider ordering issues / training issues. And it gives your end users an idea of this process from start to finish. So it really gives you the full picture. It gives you the why. If you focus on anything to avoid failures, please focus on those workflow and training to that workflow. If you, by chance, have data interface issues, that really refers to if you are using, in Epic we call it CERM, but some type of referral management system where you are trying to send referrals electronically to a different system, or maybe in Epic, those are going across Care Everywhere electronically. So that's just something to keep in mind, is data interface errors really refers to if those are hitting any technical blocks. But your EMR team should be heavily involved and heavily work with you if that's the case. But I can't stress enough, focus on those workflow issues first, and the other issues will kind of wrap up into this. Our next part here is just talking about data. It is I think this representation here with the Lego data is a really excellent breakdown of this. I like it a lot. And I think it is just a quick reminder that baseline data and the way that you set up your data should be the same from the very start of your automatic referral process. So it should be the same from when you are collecting baseline workflow and baseline data all the way through, because you don't want to change your data collection process along with your go live. You want to keep that consistent, or you're going to end up comparing kind of apples and oranges, if you will. You want it to be really consistent. And then along with this awesome Lego graphic, you want to make sure that you are not just stopping at the arranged or visually presented part. You want to take that and use that data to tell a story as much as possible. And working closely with your analytics and your QI team is going to take that data out of the system and make it meaningful and tell you what's really happening on the provider side, on the cardiac rehab side, and on the patient side with this process. So, all right. So this breakdown, I think, is just a nice representation and a good indicator of one of the ways that you can organize your data. A referral initiation versus a referral completion. What you want to collect are clean numerators and denominators on that data. We really don't want those lines to be blurred. So again, this is one example or one way that you can use data to kind of tell the story from the start to the finish. And I think they will provide a little bit more info on this particular breakdown of it. But again, the key to this is just making sure that your baseline data remains the same and that you are collecting it with this method from the very start of your project through the end of using automatic referral. Okay, excellent. And the last one that I have to speak on here for you today is just a discussion of, again, kind of referring back to that Lego slide, how to take the data off of the page and make it meaningful and apply back in to what you are doing with cardiac rehab and automatic referrals. The thing I would highly recommend is that you take the whole team and you make sure you are reviewing that data. So really actually talking about it, looking at it, seeing where the data says there may be workflow issues, and then working with, from my perspective, with your EMR team to address that if you can. So again, just really making sure you take that whole team that we talked about and have them incorporated in with the data so everybody's on the same page of what is happening.
Jumping off of that, you really want to make sure that you continually check in with your staff in order to demonstrate how the automatic referral process order set is really, in the long term, going to decrease the provider workload as well as improve overall outcomes for these patients. In particular, for mid-level providers as well as physicians, it's really important for them to see that by their use of the automatic referral, it's really having a meaningful impact. And so it's important to continuously show regular data so that they can see that this is actually leading to a hard outcome, specifically increased cardiac rehab referrals, and that it's benefiting the patient. And sometimes a really useful technique is trying to create sort of this friendly competition amongst providers, to sort of see who's having the better track record, so to speak. But another thing that you also want to do in terms of open communication is really try to see what are things that the staff may need. And you want to really minimize the use of paper referrals, making sure that everyone is aware throughout the hospital system that this is something that is being implemented. And again, it's important, as Laura had mentioned early on, that you really do have this cardiac rehab champion. You have someone who is from the higher level of the hospital administration who believes in this buy-in in order for this to be a success. With the same token, because you have the different increase in automatic referrals, you really want to make sure that the CR program has the capacity. And so having that communication between the staff is really key.
Thanks very much for your very practical insights, Sherry, Laura, and let's now start to kind of dive into some common problems that can occur as you begin the automatic referral process. And we want to encourage all of the members of the audience, if you relate to these problems, if you see variations on these problems, by all means share your questions or your concerns or observations or even solutions in the chat for us to react to, and also for the for your peers to be able to see. So let's turn to some common problems, and one of them is the automatic referral just isn't working like you thought it would in the EMR. Sherry, how would you start sorting this out? And why don't you give your thoughts on this, and then we'll turn it to Laura.
Sure. So from a provider standpoint, I was sort of heavily involved at implementing the automatic referral at my home institution. And so when this was launched, I kind of made sure that I was around on the inpatient hospital side to see the providers putting in this referral, and then keeping a list of these are the patients who were recently discharged from cardiology, who would be appropriate from cardiac rehab, and then matching that list to the referrals that we would receive at our cardiac rehab program. And so it sort of created the safety net to make sure that nobody was lost. And at the same time, it's promoting the availability of this resource so that providers are aware and that they know how to use it. And so that was sort of one of the backup options we created in case something was to happen with the lack of transmission or the, behind the scenes if an error was to occur.
Laura, any additional thoughts on this?
Yeah, thanks, Stephen. I think from my perspective, I would address first if it was a technical issue. And in Epic, at least, I don't want to speak to all different EMRs, but in Epic, we have a workflow analyzer where we can kind of go in and see keystrokes and make sure that that build is correct. Hopefully, I have been involved, or that EMR person has really been involved in and knows those workflows and can go back to notes on benchmark and initial testing and say, okay, is there a technical issue on the build first, and take a look at that, and then kind of jump in, hopefully working alongside, like Sherry mentioned, with the clinical team, and getting feedback on that to say, if there's not a technical issue, is it a workflow, and follow from there. But I would first check on the technical side.
All right, and it seems, can you just comment, because it seems like there's a soft side of responding to these problems, and you could get to the same place very, curtly and abruptly, or you could get there by acknowledging that, in advance that probably wrinkles are going to come out, and there's probably going to be things that you need to fix, and being, apologetic and supportive. So in your experiences, how important are some of those like soft skills to helping the transition to automatic referral go smoothly?
Yeah, great question, Stephen. From my standpoint, I like to approach kind of every user that you work with in thinking they are trying to do the best job possible that they can do, and have patience. And with that, I really just like to think, nobody's intentionally trying to use the system incorrectly, and give them a little bit of elbow support with that. So yeah, definitely a lot of patience in doing that, and just really trying to keep the mindset that everybody is trying to do the best job that they can possible, and going from there with a little compassion that we're all very busy.
Sherry, any of your experiences related to the soft side of dealing with people that are experiencing problems?
No, I think Laura kind of answered that appropriately. That's been sort of my take on it. It's really kind of preparing the providers as well as the staff that this is something that's going to be implemented, and we could experience some initial bumps on the road. But I think it really is helpful to really have someone who's designated, both from IT as well as maybe a cardiac rehab member who's on the hospital side to kind of double check and help out if anything was to occur with trying to troubleshoot.
All right, thanks. Let's move on to a second potential problem. And I think one of the underlying messages that you've heard, throughout the initial comments is that a lot of the problems, you can catch them and figure them out in your early testing phases or your pilot testing phases to reduce the likelihood that these things happen during the full rollout. But the second problem is, how do I know if the referrals are increasing or decreasing? So this ties into developing a solid data monitoring and feedback plan. Sherry or Laura, any questions on or any comments on looking at your data and challenges that have surfaced when you've gone through that process?
Yeah, so I mean, for me personally, I really agree with the fact that you really need to know what your baseline numbers are prior to implementing this. And so I did a recent study at our institution because I had noticed anecdotally it didn't seem that appropriate patients were getting referred to cardiac rehab. In particular, I'm at a teaching hospital, and what we sort of noticed was during the weekends, a lot of people tend to get missed because they may be, being taken care of by a resident or a fellow who may not have a true understanding of cardiac rehab. And in my study, I had sort of looked at these are the X amount of patients in the past year who were admitted onto the cardiology service, had qualifying diagnosis for cardiac rehab, and we looked and truly tracked who of these patients getting discharged was an electronic referral placed. And from that data alone, we noticed that unfortunately we were missing quite a few people, and that's sort of what led to the creation of an automatic referral process, basing off of works of Cherry Grace and Phil Adis, who have shown that this is a true way to improve cardiac rehab participation and attendance. And so I can't really reiterate enough how important it is to know what your starting baseline is. And then from there, what I would encourage is that you at least on a quarterly basis assess what those referral numbers are. And keep in mind that referral is quite different than actual participation and attendance. And so those are two different beasts, and they may not necessarily correlate. And so that's why it's important to keep track of the numbers of referrals that are getting placed from the hospital.
Yeah, thanks very much. And you raised two really important points. One is the need to make sure that you're not neglecting the weekend staff or the night staff in your training efforts, because very frequently those are problem spots. And if you never train them, or if you less of them that get trained, then that's almost inevitable. And then I think that the other point, related to working with residents is that you can't train people at the start and assume that you're finished. It's almost got to be an ongoing process because as you get new residents, they need to learn the new systems as well. Laura, anything that you want to add to this discussion about referrals increasing or decreasing, or more generally the training of the staff?
Sure. No, I think Sherry covered it very well. I think I already stressed this, but the first point here, that referral report should be created before you implement, and then just from a reporting standpoint, from somebody who writes reports, changing even one very minor thing in these reports makes it hard to be consistent. So I think it's hard to do at the start of a project, but if you put the time in to make sure that those reports cover everything that you need from the start to finish, it will help immensely. If you make one small change, it's hard. It makes it a lot harder. So just consistency in terms of reports is my soapbox.
Yeah, thanks very much. And it's just, I think it points to the importance of involving your entire team in the development and review of those reports, because, you know, some of your team members may focus on some things, others may focus on others. And at the end of the day, you want a report that's going to work for all of them. So let's move on to our next potential problem. The automatic referral seems to be working. You're identifying the right patients. You're prompting the physicians, and they seem to be referring the patients, but the referral numbers aren't necessarily going up. So, or the enrollment numbers aren't going up. So, Cherry, Laura, your thoughts on how to address this challenge?
I mean, for one thing, and Laura can speak to it more, is maybe perhaps there is still some type of underlying workflow issue from the IT side. And maybe perhaps it's working for some, but maybe not others, depending on where in the hospital if there's a particular issue. But really, to me, what the bigger picture is, unfortunately, people don't have a full understanding of the utility of cardiac rehab and who qualifies. And so it just goes back to the fundamental basics of providing education, both to not only the providers, you know, and there's a really huge impact of having the physician recommending cardiac rehab at time of discharge, but also the mid-level providers, the nurses who spend a huge amount of time with the patients. These are all sort of checks and balances to ensure that the appropriate patients are being referred to cardiac rehab. And so if you know that you have a truly sound automatic referral system in place, and yet you're looking at no increase in the referrals, then this is really going back to lack of education and awareness. And so resources should be spent on really having different people become familiar with the utility of cardiac rehab. And then one of the things that we've done in our own institution is we have volunteers who come in, who've been former participants at cardiac rehab, who will come and chat with our cardiac patients. And that sort of has been a way for patients to become more engaged in the program. And so if for some reason it was missed and wasn't mentioned by a nurse or the physician, then the patient can actually bring it up themselves because they were aware of it from speaking to a hospital volunteer.
Yeah, thanks very much. And that, I think, points to the intersection between the automatic referral processes and the care coordination, since, you know, they are interdependent, and you're not going to really get to where you want to be without working on both. And that's a good example of that. Laura, anything further you'd like to comment on this?
Yeah, thank you, Stephen. And from, I think Sherry's points are very good and very much oriented towards the clinical side. From my perspective on the more technical side, I have learned the baseline workflow lesson many times over again the hard way. So from where I stand on the IT side, if you take the time ahead of designing a build to understand how your clinicians are using the system today, you are just going to build a system that already aligns with their workflow. From an Epic side, I can think of at least 4 to 5 different ways to actually implement or build in an automatic referral for cardiac rehab. But the best way for your system is based on how your providers are using the system today. My team refers to this as don't make anybody swim uphill as much as possible. Try to not add new buttons. Try to not have them go to a whole different form. Try and build it in automatically to how they're placing those referrals today. And you're really going to eliminate heavy burden. You're going to eliminate errors as much as possible. And they'll just be appreciative. They're, you know, we're all very busy. As much as possible, do that baseline workflow analysis and build that automatic AR into what they're doing right now. So this is probably my big passion topic.
Absolutely. And making the right thing to do, the easy thing to do. is going to work a lot better than trying to, get them to do the right thing when it's not the easiest thing to do. And just as a reminder for those that are in the audience, Module 3, we talked about process mapping and the importance and foundational elements to process mapping. So the resources related to Module 3, both the slides as well as the implementation guide, have some practical suggestions to help you work through that process. We encourage you to work on that earlier, but it's never too late to work on that. And really, most people would say that if you find that you've got problems with the workflow, the time to address them is before you try to automate them instead of afterwards. So very good suggestions from both Sherry and Laura here. All right, let's move on to yet another challenge. The providers seem to have developed a workaround or opt-outs, and so we're not getting referrals. Have you had experiences dealing with this? And if so, how'd you respond?
I honestly have not had issues thus far in terms of that particular problem.
Yeah, and Stephen, not necessarily specifically to automatic referrals for cardiac rehab, but from the Epic side, we see this all the time. And it really, again, sorry, ties back to that baseline workflow topic where, if you've implemented a system and maybe you went and met with your EMR team and they said, this is some really cool functionality, it looks great, you've implemented that, but it is a process that none of your providers follow, or, it just is not right for your system, then I think you have to kind of have, although it's difficult when you've gotten that far down a go live process, to stop and reevaluate and say, do I need to scratch this and do a rebuild? Very difficult. But again, I think also approaching from the mindset that nobody is trying to do a bad job. Nobody is trying to not get these automatic referrals in. It's just maybe there is something in the system that is preventing that from being easy. So.
Yeah, thanks. And we've got a question from the audience. As a provider, do you find the inappropriate diagnosis is often auto-selected on the referral? We're finding that the admitting diagnosis is used on these referrals, which causes a lot of work for the CR team members to get this corrected. So, and I think what she's getting to is that if they don't have the correct diagnosis, then the patient doesn't necessarily meet the eligibility criteria, and so they may not get automatic referred, or there may be problems down the road with approving their care to their insurer. So thoughts on how to advice for people that are encountering this challenge?
Yeah, so that's an excellent question. Sort of what we did, because I was very involved in actually creating the order myself, and I serve as like the assistant director of cardiac rehab. And one of the things I wanted to kind of ensure, and I agree with this comment, is that the admitting diagnosis is oftentimes quite different than the discharge diagnosis, and doesn't necessarily mean that that person will qualify for cardiac rehab. So what we had created for part of our automatic referral is that it's sort of a hard stop as to if you are discharging a patient from the cardiology service or from the cardiothoracic surgery service, you have to fill and decide whether or not you are going to place the referral to cardiac rehab. And so when you place that referral, it shows you these are the qualifying diagnosis for cardiac rehab. And so it sort of serves as a reminder or a little bit of a checklist for people to know what does and doesn't count. With that said, we still do have people who get referred with an inappropriate diagnosis. More often it tends to be a diagnosis of like cardiac arrest or diastolic heart failure, HFpEF patients. But surprisingly, we've sort of been looking at the data, and those referral numbers haven't dramatically increased compared to what it was in the past. And I think by having some information that's linked to the order kind of will help minimize these inappropriate referrals.
All right, thanks very much. And one other question is opt-out referral and automatic referral the same thing?
Yes. In my mind, I would sort of describe it as the one and the same. So usually with automatic referral, what it sort of means, and Laura can speak to this more, is how you have it set up. So for our program, it's set to, you will be automatically referred, but you have to fill in the reason for the referral, which is the qualifying diagnosis. If you decide that this patient does not meet these qualifying diagnoses in the checklist, then you will click no referral, which would be an opt-out. And so the main kind of difference is that with an automatic referral, you are automatically checking like, yes, this person needs to go to cardiac rehab. And so there is some thought into, again, putting in the qualifying diagnosis or the opt-out, realizing that this patient isn't appropriate for cardiac rehab. And I think, and I had talked about this with Laura, discussing her experience, is that there are different ways to go about it. Some programs may choose to link it in with ICD codes or so forth. And that was just something that I didn't want to pursue, and I thought it would be too challenging. And so that's sort of where we kept it a little bit more simple with a checklist.
Yeah, and a comment from Stacy Greenway, which is surfaced before, relates to, you know, somebody's not using the order set that we have the automatic referral built into. And again, this is something where facilities differ, and, you know, some places have, you know, a discharge data or a discharge order set that pretty much everyone has to use. And that makes it a little bit easier to avoid that problem. Other times, if there are multiple order sets that they can be using, it's a little bit more challenging. So Sherry or Laura, any observations on what to do when they if a facility has that scenario?
Yeah, I think in terms of sort of my experience, you know, we have one cardiac order set for discharge that majority, I would say 95% of people use. And with that comes the same order set for patients who are discharged from the EP service, and they may not necessarily be eligible for cardiac rehab. And so knowing that this is something that was routinely used by my colleagues, you know, I spoke with the hospital administrator as well as our division chief to kind of explain, like, yes, this may be a little bit of additional work on the front end, but in the long run, it's not only better for patient health and satisfaction, but it will reduce hospital costs, because if you participate in cardiac rehab, you're less likely to have a recurrent cardiac event. And so I was very open with my division chief saying, you know, my EP colleagues may be annoyed that they have to be forced to click this. And he believed in what we were doing and the importance of that. And so we just educated everyone in the division as to, this is going to have an impact, just like how you have to decide on a code status, whether someone is, you know, full code versus DNR and DNI. Sort of the same thing comes in terms of a cardiac patient. And if anything, you know, this sort of increased the volume in terms of those patients who, let's say, have atrial fibrillation, and oh, by the way, they also have systolic heart failure with the EF of 35%. We're now capturing those patients, which we would have missed before. And so it's been really beneficial in the long run, but there was initial hesitation. And so you really need to have something that's consistent, and it may not be applicable to everyone, but they have to value the importance of having us.
All right, thanks very much. Let's just go to this last problem. I'm sensitive to the time. Everything seems to be working bad. The patient's referred, but they just don't come. And this is really the intersection between automatic referral challenges, and it's possible to build alerts in to remind the providers that somebody that is eligible hasn't chosen to enroll. But this is also a care coordination problem. And in the next two modules, we're going to be talking in a lot of detail about strategies that you can use to work with patients that do have concerns about participating and help them to maximize the number of referred patients that actually do enroll in your program. We'll transition now out of the problems section and talk a little bit about extending and spreading your automatic referral use. Because once you've got this completed, then you may want to consider areas where you could conceivably accelerate the referrals, expanding your outreach to including eligible patients in other hospitals and practices that use your EMR. Will be a little bit harder, but if it's the same EMR, it's more doable. And then using it with hospitals or practices where they may have a different EMR. But if that's an important source of referrals for your cardiac rehab unit, those may be options that you want to consider. Now, once you've completed the AR order set, then you may also want to extend it even further to ones that you can't interface with, or even facilities that may not have an EMR altogether, or that just aren't willing to work closely with you on this. So there are ways that you want to extend and spread this, but we really encourage you to start with something that's more basic so that you can get it in place before you work to expand or spread. All right, thanks very much for those insights, and they are very useful, and we want to encourage you to enter into the chat any insights that you picked up in the call that you or in the conversation today that you think will be beneficial for your program and your automatic referral implementation, or to add any questions that you have for Kathy Briggs and for us to answer either on the call at the end or in a subsequent email or in a peer action group. Kathy, any short reactions to what you've heard? Any things that you want to emphasize in just a minute or two before we wrap up? And you may be on mute.
Sorry. One of the key pieces I really think is collaboration with your IT friends. Finding those folks in the IT department, the folks who are clinical informatics specialists, who really you can work with them, find common language, to help meet your goals with your automated referral. We're really good at listening and teaching skills, and so finding a friend in the IT department and having them help you to meet your goal with automated referrals. I know, we started real simply with that consult to cardiac rehab in Cerner, and I'm very fortunate. All of our cardiologists and our CT surgeons want all their patients in cardiac rehab. So I never encountered any hurdles to automating referrals and didn't have to use my elevator speech very often. But it really helps to have the IT folks to take your vision and your goals and turn them into what works in the computer system, because we're good at taking care of those patients. We're good at doing the patient care, but the computer side isn't necessarily our expertise. So collaborating and finding the right folks to help you to make that happen really makes a big difference.
All right, thanks very much, Kathy, and the other panelists for their insights today. And by all means, if you have additional questions, we want you to ask them in your peer action groups, which will be coming up next week. We want you to continue action planning and sharing your action plans on a monthly basis, since that can help keep you on track. And the discussion in the peer action groups are really the next way to get your insights shared and your questions answered. We want to also remind you to take a look at the implementation guide. There's lots of valuable information in that as well. So just looking ahead quickly, Provide your peer action group day preferences so that you can get signed up for that and participate in that. And then module 8 will be on June 8th at from 2 to 3, and you can register using the link in the slides, or we also send that as a separate email. So thank you all again very much. We'd appreciate it if you provide a response to the feedback questions at the end. And if once you've done that, we hope you have an excellent rest of your day. And we really appreciate your commitment to doing all you can to maximize the quality of the care that your patients are receiving. So thank you very much and have a great afternoon.